I'm going to mention two of them in two different leukemias. One is the frontline study of asciminib. On this study that's called the ASCO first, that randomized patients to asciminib or any of the approved options for first-line therapy in CML. And this was shown for the first time at ASCO. It's the first time that the results are disclosed. And it showed that the primary endpoint, which was a major molecular response at 48 weeks, was met. And there were two comparisons. There were co-primary endpoints, asciminib versus imatinib or asciminib versus all available TKIs, and both were met. And the toxicity profile was equal or better with asciminib compared to these other options. So the follow-up is short, but I think it is very possible that the drug will be approved for frontline therapy, and it may translate into the next important next step in the advancement of the treatment of CML. Then we're going to have to figure out what's the right patient to use it on. But it is, I think, an important advance in the treatment of CML. The other study that I liked a lot was this study where, and this is a retrospective analysis, but the investigators from France presented their approach of using azacitidine venetoclax for patients with AML unfit for chemotherapy, where they capped the venetoclax at 7 days. And then they presented a comparison to a cohort from MD Anderson with the standard approach of venetoclax for 28 days per cycle. And what they showed is that overall the response rate is the same, the survival rate is the same, but there is less mortality by 8 weeks. There is less of a need for platelet transfusions. So it may be beneficial for some patients. The one caveat is that patients who have a high likelihood of benefiting from venetoclax, which is specifically those that don't have P53, those that don't have FLT3 mutations, and those that don't have a RAS mutation, those seem to benefit from the more standard approach. But otherwise, other patients may benefit from a condensed strategy, which I think is beneficial if we can minimize the risk of infections and death and platelet transfusions and so on.